Well, good morning to everyone. I am Dr. Laura Lacher, and welcome to this week's Medical Grand Rounds. Per usual, we will get started with some reminders, logistics, and then very special introductions for today. Next week, we will not be hosting Grand Rounds to take a break for the Thanksgiving week, so go ahead and enjoy a bit of rest, and be sure to rejoin us the following week on Tuesday, December 3rd. We'll be hosting Dr. Justin Jin, who will be giving a talk on updates in tuberculosis. And just a reminder, Grand Rounds is a collaboration between Providence St. Vincent and Providence Portland Medical Centers. Welcome to everyone out there on Teams Live. We often meet in person, that is Tuesdays at 8 a.m. in Southern Auditorium at Providence St. Vincent, and occasionally live at noon, also on Tuesday at Providence Portland. We are always here on Teams Live. You can earn CME credit by joining in the live in person in the room, by watching live virtual, or by watching a recording of the event. And that recording is always available as the same link as the weekly Grand Rounds invite. I'll be monitoring the Q&A throughout today's presentation, so please go ahead and post any comments or any questions, and I will hold those as time permits to ask at the end of today's presentation. I am particularly excited for today's talk. It is the 2024 Dr. Jeffrey Clavin Lectureship. This lectureship, established in 2018, seeks to bring an exceptional educational program with particular emphasis on lifelong learning and high-value care. Dr. Jeffrey Clavin joined the Portland Clinic in 1977, and in 1994 was named the Chief Medical Officer, where he was instrumental in the clinic's focus on the triple aim of access, cost-effectiveness, and quality outcomes. And this lectureship honors the long-standing relationship between Providence and the clinicians and leaders at the Portland Clinic. And I am certain Dr. Clavin is out in our audience today, as he is every week for Grand Rounds. So glad to have you with us, Dr. Clavin. And now to introduce today's speaker, we are joined by Dr. Richard Hoffman, an emeritus professor of medicine at the University of Iowa, Carver College of Medicine, and previous director of the Division of General Internal Medicine and co-leader of the Cancer Epidemiology and Population Sciences program at the Holden Comprehensive Cancer Center. He attended medical school at the Johns Hopkins University School of Medicine, and then internal medicine residency at our own Oregon Health and Sciences University, followed by general medicine fellowship at the Seattle VA, and he received an MPH degree from the University of Washington. Dr. Hoffman is widely recognized for his expertise in prostate cancer screening. For many years, he authored the up-to-date chapter on this topic and has spoken on this topic at many professional conferences. He served as an expert advisor for prostate cancer screening guidelines issued by the U.S. Preventive Services Task Force and the American Urologic Association. He is currently a member of the American Cancer Society's Guideline Development Group, where he's helping to update the prostate cancer screening guideline. Dr. Hoffman has worked on prostate cancer screening patient decision aids for UpToDate, the Informed Medical Decisions Foundation, and the CDC. He has received considerable federal funding to study prostate cancer screening and treatment and has nearly 100 publications on prostate cancer, including invited reviews and commentaries. He is a true expert in this field, and I am delighted to learn from him today. Thank you, Dr. Hoffman.
Thank you. Thank you for that introduction. Can everyone hear and see?
We can. Thank you.
So yeah, I'm really honored to be invited to speak today, and I have many fond memories of my time in Portland, including a 1-month rotation at St. Vincent's. So my title is Navigating Prostate Cancer Screening, Evidence, Controversies, and Shared Decision Making. My disclosures: I have no financial conflicts with this topic. I want to begin with a prologue. I was a general medicine fellow in Seattle, and we learned how to critically appraise the medical literature. One year we were looking for articles on evaluating diagnostic tests, and we found this study in the New England Journal about PSA. This was an observational study. Investigators invited over 1,600 men to come in for a PSA test. If the PSA was 4 or more, they underwent a digital rectal exam and a transrectal ultrasound. If either of those tests was abnormal, they had a biopsy. They found 37 cancers. It turned out that PSA found cancers that were not detectable with digital rectal exam. And so they recommended that the best screening strategy would be to combine PSA and digital rectal exam. They also found 18 men with prostate cancers with PSA levels between 4 and 10. All of those cancers were clinically localized or therefore potentially curable. We thought this was an interesting study, but we didn't think PSA screening was ready for prime time. We were wrong. I was at a conference a couple years later, and I learned that PSA testing was widespread and that we were in the midst of an epidemic of prostate cancer. The annual incidence rate had almost increased by 2.5-fold since PSA was introduced. I found this disconnect between the evidence and clinical practice to be perplexing, and it sparked what's become a career-long interest in prostate cancer screening and outcomes. My objectives for the talk today are to help you interpret the epidemiologic and clinical trial data that provided the rationale for prostate cancer screening guidelines, to define the concepts of shared decision-making and decision aids, and to describe how to address racial disparities in prostate cancer. I'll begin by discussing prostate cancer screening controversies, which have been persistent over time. We'll look at the consequences of prostate cancer screening guidelines, and then spend the last part of the talk discussing how we can maximize the benefits and minimize the harms from prostate cancer screening. What I realized was my being perplexed about prostate cancer screening in terms of the disconnect between the evidence and practice had been foreshadowed in the 18th century by the British writer William Cowper, who wrote that the absence of proof is not proof of absence. And what happens is when a new cancer screening test is introduced, it creates two warring factions, which were described by David Sackett, the guru of clinical epidemiology, as the evangelists and the snails. The evangelists see prostate cancer as one of the deadliest cancers and a cancer that's not curable when it presents at advanced stage. We now have this new test, PSA, that can find more cancers and can find them at an earlier stage when they're potentially curable. The feeling of the evangelists, it'd be unconscionable not to offer this test to all American men. So the evangelists were the American Urological Association and the American Cancer Society, who in the early 1990s recommended routine annual screening with PSA and digital rectal exam. They recommended starting at age 50 for average risk men, age 40 to 45 for high risk men, those with family history or African Americans, and stopping when life expectancy was less than 10 years, which based on actuarial tables was somewhere around age 75. But the snail said, well, we don't have enough evidence to support screening. We don't know that PSA screening is actually going to reduce prostate cancer mortality. And we have to be worried about potential harms, false positives, overdiagnosis, overtreatment, complications from treatment. And the snails, of course, were epitomized by the US, getting ahead of myself. The consequences of these guidelines was that more than 1.3 million additional men were diagnosed with cancer, and 1 million of them were treated for prostate cancer with radiation or surgery. But as I said, the snails didn't find the evidence convincing. And so the snails were epitomized by the US Preventive Services Task Force, who in 1989 and 1996 recommended against PSA screening. In 2002, they concluded there was insufficient evidence to make a recommendation. 2008, there was still insufficient evidence to make a recommendation for screening, but they said there was evidence to recommend against screening beyond age 75. What they were looking for was evidence from randomized controlled trials, showing that men who were randomized for screening were less likely to die from prostate cancer than those who were not. And in the early 1990s, 2 randomized controlled trials were launched. The European Randomized Study of Screening for Prostate Cancer, or the ERSPC, and the United States, the Prostate, Lung, Colorectal, and Ovarian Cancer Screening Trial. But it takes many, many years for randomized trial results to be available to inform clinical practice. So we look for other sources of evidence. There was indirect evidence for screening effectiveness. We saw a decreased incidence of distant stage cancer. These are data from the Surveillance Epidemiology and End Results, or SEER registry. The y-axis is rate per 100,000. The x-axis is year of diagnosis. I draw your attention to the area in the red box. That red line is the incidence of distant stage cancer, which was significantly decreasing since PSA was introduced. That's considered an early sign of an effective screening program. Over the first decade or so of prostate cancer screening, prostate cancer mortality rates declined by 30%, and modeling studies attributed 45 to 70% of this to screening. But there's also some indirect evidence for screening harms. So again, looking at this incidence graph from the SEER data, what I've highlighted here is the marked increase in the incidence of localized cancers. And autopsy data at the time had shown there was a 30% prevalence of occult prostate cancer among men 50 and older. So the concern was that by finding all these early stage cancers, we were actually overdiagnosing cancers, reaching into that reservoir of cancers that never would have been diagnosed in the absence of screening. And that overdiagnosis rate was estimated to be up to 44%. Overdiagnosis in itself can be a problem just because the stress of being diagnosed with cancer, but it also led to concerns about overtreatment. For many years, more than 80% of men with localized prostate cancer were aggressively treated with surgery or radiation. And these treatments have substantial risk for urinary, sexual, and bowel complications. And interestingly, for prostate cancer, the first randomized trial data supporting the benefit of any treatment for early cancer wasn't published until 2002. And that was a Scandinavian study that looked at radical prostatectomy. So we sort of did things backwards with prostate cancer. Usually you start knowing that treatment is effective at the time of clinical presentation, and then you decide whether it's more effective at the time of screening diagnosis, but we didn't do that. So with all this indirect evidence, there was actually a consensus across guidelines in endorsing informed decision-making rather than routine testing. And everyone agreed that the outcomes of the trials were eagerly awaited. In March of 2009, the New England Journal published back-to-back articles on the European randomized study of screening for prostate cancer and the prostate, lung, colorectal, and ovarian cancer screening trial. The ERSPC was a randomized trial of over 180,000 men, ages 50 to 74, conducted across 7 European countries. The study arms, the screening arm got PSA every 2 to 4 years. The control arm was usual care. The outcomes, which were measured at a median of 9 years of follow-up, were initially reported for a predefined core age group of 55 to 69. They found a couple interesting things. First of all, cancer incidence was markedly higher in the screening group, 71% increase. But there was a relative mortality risk reduction of 20%, and this was statistically significant. So screening was effective. But you need to recognize that the absolute risk reduction was small, 0.71 fewer deaths per 1,000 men. Or another way, words, you needed to screen 1,400 men, basically an average of twice over 9 years, to prevent 1 prostate cancer death. And then there was the American study. This was a randomized trial of over 76,000 men, ages 55 to 74. The study arms were annual PSA and digital rectal exam or usual care. The outcomes were reported at a median of 7 years follow-up. There was a 22% increased incidence of cancer in the screening group. There were 6 more deaths. So this was a resounding negative study. The first round of controversies then arose on interpreting the evidence. The American Cancer Society updated their guidelines after these studies came out and came out with a strong recommendation for shared and informed decision-making. They recommended addressing screening with asymptomatic men with a 10-year life expectancy. Again, average risk men at 50, higher risk men at 40 or 45. American Urologic Association, similarly, shared decision-making for asymptomatic men ages 55 to 69 with 10 to 15-year life expectancy. Routine screening was not recommended for men between 40 and 54 or 70 and older, though they did note that higher risk men might benefit from earlier screening. I want to just take a segue here. The term shared decision-making is being introduced for the first time in terms of screening, and I want to provide some definitions. One that I like is it's a collaborative process that allows patients and their providers to make healthcare decisions together, taking into account the best scientific evidence available, as well as the patient's values and preferences. And shared decision-making supports quality decisions about preference-sensitive care. And preference-sensitive care is defined as interventions that involve significant trade-offs affecting the patient's quality and/or length of life. So again, whether or not to screen for cancer. And the key point about this is that an informed person may reasonably decline care. This is a model for having this screening discussion that was outlined by Glyn Elwyn, a decision scientist at Dartmouth. And he talks about three components. The first is team talk, letting the patients know that they have a decision to make and that you will work with them to help make their best decision. The second component is option talk. What are the options? What are the screening tests that can be performed? What happens if you don't screen? What are the potential benefits, outcomes, and uncertainties of these various strategies? The final part is decision talk, making sure that the patient understands the issues, so are informed, and finding out what values they have, what outcomes are important to them, and then what their preferences are. That's a lot. And the American Cancer Society guideline recognized that given the complexity of these issues and the time constraints faced by healthcare providers, we encourage providers and patients to use prostate cancer screening decision aids to facilitate the process. So decision aids are educational tools that provide evidence-based information about a health condition, the options, associated benefits, harms, and uncertainties. That they help the patients to recognize the value-sensitive nature of the decision and to clarify their preferences, and also to provide some structured guidance in the steps of decision-making and communicating informed values to providers. What are the benefits of decision aids? Well, the Cochrane review, which looks at all randomized trials, evaluated over 120 studies of patient decision aids. They said there's high quality evidence that using decision aids will increase knowledge about options. It will improve the accuracy of risk perceptions. It will increase engagement in decision making and reduce decisional conflict, meaning people are more confident that they made the best decision for themselves. There's only moderate quality evidence that there's increased congruence between values and options. And basically this is saying that if there's someone who really clearly has a high value on doing anything possible they can to avoid dying from prostate cancer, then their preference should be for screening. And if it wasn't, that would be a discongruence. And then in the middle of this, the task force issued their updated guidelines. And it was a bombshell. Grade D recommendation. They recommended against providing PSA screening to men without suspicious symptoms, regardless of age, race, or family history. They argued that the mortality benefits of PSA cancer screening through 10 years are small to none. And this was based on looking at both the ERSPC and PLCO. The harms are moderate to substantial. And the harms they called out were false positives, biopsy complications, and overtreatment, recognizing that most men with localized cancers were undergoing active treatment and treatment complications were common. So what were the consequences of these guidelines? Well, PSA testing rates decline. These are data from the National Health Interview Survey. And what you can see is between 2010 and 2013, there was a marked decrease in screening across age groups of 50 to 74 and 75 and older. You also, though, can see that starting in 2008, when the task force recommended against screening older men, that their screening rates had begun declining that far back. Prostate cancer incidence declined. These are SEER data, again, looking at incidence per 100,000 men, year of diagnosis. The guidelines were actually issued as draft form in 2011, and so they impacted in 2012. There was an astounding 33,000 fewer cases, and this was clearly related to the change in screening practice because there's no other biological explanation for why cancer incidence would have decreased. The only comparable benefit I could see is if everyone miraculously stopped screening overnight, we would see a decline in lung cancer screening, but probably not, or lung cancer diagnoses, but not likely that soon. There was also some concerning findings. Distant stage incidence increased. And again, what you see in the red box is that incidence increased in men 75 and older. And prostate cancer mortality declines stalled. Again, this is SEER data looking at age-adjusted rate of prostate cancer-specific mortality per 100,000 across year of diagnosis. The different colors and shapes represent different age groups. And what you can see was all age groups were significantly declining before the new guidelines. After the new guidelines, those mortality curves flattened out, except for the younger men between 60 and 69, who actually showed a small but statistically significant increase in mortality. So in 2018, the task force rethought their guidelines. And now it became a grade C recommendation for men ages 55 to 69. And they tied that to the ERSP initial report for men in that age group. What they said was there was moderate certainty that the net benefit is small, and they recommended informed decision making. They continued offering a grade D recommendation against screening men now ages 70 and older instead of 75. There was no recommendation to screen high-risk men at an earlier age. Why the change? Well, we had more data from the RSPC. What they found with longer follow-up is that instead of avoiding less than 1 death per 1,000, that number was between 1 and 2. They also found that screening prevented 3 cases of metastatic cancer per 1,000 men. We also had new data on PLCO. So through 19 years now, there was still a few more deaths in the screening arm and the control arm, but we realized this study was flawed. 80 to 90% of men in the control arm had undergone PSA testing during the study. And even the study investigators realized this was not a randomized trial of screening. It was a comparison of organized versus opportunistic screening, which meant these results really were not valid in assessing prostate screening. But the other important thing was there was an increase in deferring active treatment. So for many years, only about 10% of men who were diagnosed with low-risk cancers did not get aggressively treated, usually with surgery or radiation. But by the most recent time period, you can see in the red bar, up to 40% were not getting actively treated. They were getting active surveillance or watchful waiting. So I want to explain these terms in a little more details. Watchful waiting is offered to men who will not benefit from cancer treatment due to limited life expectancy or comorbidity. It's described as expectant management with palliative intent. Will offer interventions only for symptom control. Active surveillance, though, is expectant management with curative intent. It's offered to men with low-risk cancers. It delays offering curative treatments until warranted based on indicators of disease progression or patient choice. And the surveillance includes PSA testing, digital rectal exam, biopsy, and now increasingly MRI. This is a strategy that's been recommended by the American Urological Association, the National Comprehensive Cancer Network. And we have evidence for this. There's actually randomized trial data from the Prostate Testing for Cancer and Treatment, or PROTECT study. This study enrolled 1,643 UK men who had PSA detected localized cancer and were randomized to either active monitoring, radical prostatectomy, or radiotherapy. And what they showed, this is looking at the probability of undergoing radical interventions with years of follow-up. And so focus on the gray line, the active monitoring. Eventually, at 15 years out, about 60% of men did switch over to active treatment. But what that meant was for the majority of that follow-up time, most men did not undergo active treatment. They were spared the potential complications from active treatment. And those complications will occur immediately with treatment and will often be lifelong. So that was a clear benefit. But the big question is, how did they do with clinical outcomes? And what was very reassuring is prostate cancer mortality was low, about 2.7%, and it was similar in all groups. There was a higher rate of progression in the active monitoring group compared to the active treatment. About 9% of men developed metastatic disease for 5% in active treatment. But this study was doing active monitoring differently than we do in the United States. They monitored only with PSA, not biopsy. And they also enrolled men with intermediate risk. So about 20% had a Gleason score of 7 or more. In the United States, active surveillance is recommended for men with low risk or even very low risk, and those men have Gleason scores of 6. So what that means is now there is harmony. The guidelines all align around offering shared decision making. The task force and the ACS are actually undergoing updates, but everyone agrees on shared decision making. But there are still controversies, particularly around earlier screening for high-risk men. The AUA, the ACS, the Prostate Cancer Foundation all recommend earlier screening for men with increased risk to strong family history of prostate cancer, germline mutations, and Black race. The task force does not recommend earlier screening for high-risk men because they argue there's no randomized control data. But there is considerable evidence why this might be an important strategy. Epidemiologic data. Self-identified Black men in America are the demographic group with the highest burden from prostate cancer. These are SEER data showing age-adjusted incidence by rate. Y-axis is rate per 100,000. The x-axis is year of diagnosis. And you can see this is looking at various races and ethnicities. And what's striking is the upper curve. Non-Hispanic Black men, significantly higher incidence than all other racial and ethnic groups. Distant stage incidence by rate. Again, SEER data, rate per 100,000, and non-Hispanic Black men have over twice the risk, the rate of being diagnosed at distant stage as do non-Hispanic white. Age-adjusted mortality by race, similarly, looking at rate per 100,000 on the y-axis, year of death on the x-axis, Black, non-Hispanic Black men, consistently higher age-adjusted mortality than all other racial and ethnic groups. Age of diagnosis by race. And again, highlight the red box. What you're seeing is that non-Hispanic Black men are being diagnosed with prostate cancer at least 5 to 10 years earlier than other racial and ethnic groups. What about screening? Well, the data from the Behavioral Risk Factor Surveillance System, which is basically population-based random digit dialing, suggests that screening rates are pretty comparable between white men and Black men. Now, the validity of these reports are always questionable because of selection bias, but at least they have an internal consistency. And so we are seeing comparable rates, somewhere approaching 50%. But when you look at the younger age groups, there are some differences. We know that Black men are higher risk and they have more screening. They are more likely to be screened than white men, but look at the screening rate. It's less than 20%. So in this very high risk group, screening is not happening. There's also epidemiologic data on the other high-risk groups. So family history of prostate cancer, brothers and sons of men with prostate cancer, particularly whose cancer was diagnosed before age 60 or was lethal, have a 2.5-fold higher risk for prostate cancer diagnosis. A family history of BRCA mutations or hereditary non-polyposis colorectal cancer or Lynch syndrome are also associated with increased prostate cancer risk. I want to spend the last part of the talk discussing how we can optimize prostate cancer screening. What can we do to maximize benefits? I'm going to talk about earlier screening for high-risk men and shared decision-making. What can we do to minimize the harms of screening? And that looks at appropriately offering screening, limiting overdiagnosis, and limiting overtreatment. So what about earlier screening? Much of the emphasis has been looking at race-based screening. The idea is that you could reduce disparities in the population burden of disease. And what we've recognized, even though guidelines have talked about using African ancestry as a risk, it's not a biological characteristics. Race is a social construct, and the risk that we see is for American men self-identified as Black. Earlier screening for men who self-identify as Black is still not going to address broader health disparities. We know there's barriers to treatment access, which can be successfully eliminated, as we see from research from the VA and the Department of Defense, and there's also going to be structural racism. I believe that broad uptake of early screening for high-risk men would require the Preventive Services Task Force endorsement. Even though ACS and AO have been saying this for a long time, it's clear that the clinicians are not responding because the task force provide the most influential guidelines for primary care. And the task force cites lack of clinical trial data on the benefits of early screening for these men as a reason for not making that recommendation. But the reality is there's no evidence from screening American men. The only study that's shown a benefit is the European randomized study of screening. There is a solution, modeling, and there is a precedent for doing this with lung cancer screening. What we saw was that there were disparities in screening eligibility based on race, ethnicity, and sex that emerged after the initial guidelines, which were based on enrollment criteria for the National Lung Screening Trial. And no one really expects clinical trial enrollment criteria to be guidelines for population-based screening. So what the task force did was they used microsimulation models looking at natural history of lung cancer and different birth cohorts to identify the most efficient screening strategy that had the greatest benefits. And what they ended up doing was modifying the eligibility criteria. They lowered the starting age and the PACU requirement and essentially doubled the number of Black, Hispanic, and female adults who were eligible for screening. So they certainly could do this for prostate or for prostate cancer screening, and they're likely going to be, but I think they are more likely to consider an across-the-board recommendation for earlier screening age versus targeting risk groups. There are some evidence, observational studies, case control studies, showing that baseline PSA in men ages 40 to 49 is significantly associated with the risk of lethal prostate cancer later in life. And some experts argue that we need to reconsider doing risk stratified screening based on that midlife PSA. But again, in the absence of randomized controlled trial data, it's certainly possible that the task force may not recommend earlier screening for any group. So what are my recommendations to get around that? I think healthcare systems should have reminders for clinicians to discuss prostate cancer screening with all eligible subjects, and there should be a prompt for earlier discussions for high-risk patients. But the flip side is that medical records should have detailed and accurate family history of cancers to identify these high-risk patients. We need to be capturing data on prostate cancers, the BRCA mutation-related cancers, and on Lynch syndrome. The next thing I think that could help is shared decision-making, but I've described what a shared decision-making discussion should be, but I think behind that has to be an intention to offer screening discussions to all eligible men. There are a number of ethical principles behind shared decision-making. Beneficence. We have a test that can reduce mortality and morbidity, and we should offer that to men who are eligible. An equity issue. Black men report limited knowledge about prostate cancer and PSA testing. They report that the screening discussions are infrequent and inadequate. And in national survey data, among men who do not have shared decision-making discussions, Black and Hispanic men are much less likely to undergo screening than white men. And then there's the principle of autonomy. Men should be able to make informed decisions based on values and preferences. Am I being overly harsh on the need to have this, or dogmatic on the need for insisting on shared decision making? I don't think so. I was part of something called the Decision Study. This was a telephone survey of a randomly selected national sample of adults who were 40 years and older who either underwent or discussed preference-sensitive care in the past 2 years. This included cancer screening, it included elective surgeries, it included starting certain medications. 375 participants completed the prostate cancer screening module. What we found was their self-reported descriptions of these screening discussions. They were clearly not meeting shared decision-making criteria. Overall, 70% reported discussing screening before making decision. That meant that 30% of the men didn't even know they had a PSA test until someone told them the result. Clinicians routinely emphasize the benefits of screening, about 71%, but infrequently address the cons, less than a third. And the ideal is a balanced discussion of benefits and harms. The majority of subjects, 58%, felt well informed about prostate cancer, but nearly half failed to correctly answer any of 3 knowledge questions. And we were pretty lenient in what was considered the correct answer. We asked about the lifetime risk of prostate cancer diagnosis and death and the predictive value of PSA. And what we found was that men markedly overestimated the risk of being diagnosed with cancer, the risk of dying from cancer, and also overestimated the accuracy of PSA. Clinicians usually recommended screening about 3/4 of the time, but often 45% did not ask patients about the preferences. So clearly shared decision-making was not happening. Now that study was published in 2009. It's a persistent problem. We did a follow-up national survey about 5 years later, still found a lack of shared decision-making in discussions of colorectal, breast, and prostate cancer screening. And it's not occurring in lung cancer screening discussions at this time, even though it's mandated by the Centers for Medicare and Medicaid Services as part of their coverage determination. One thing to consider for facilitating this are patient decision aids. I worked on a number of decision aids. This is for the informed medical decisions, CDC, and UpToDate. But I recognize that the evidence is not overwhelming. This was a meta-analysis of 19 randomized trials of decision aids. They showed that decision aids could improve knowledge, but the evidence was low quality. Could reduce decisional conflict, but the evidence was moderate quality. More concerningly, decision aids did not impact whether screening was discussed or the decision to undergo screening, though the evidence was low quality. However, there were some important limitations. A lot of the decision aids that were studied in this meta-analysis used outdated information. Particularly, they didn't include the data from the randomized controlled screening data or address active surveillance. The implications are that you have to use decision aids with current information on screening and treatment, and we really need to evaluate strategies for facilitating discussions. So what are my recommendations? Make shared decision-making painless. We all recognize that having that shared decision-making discussion is time-consuming, doesn't work well in a busy schedule. But I also realize that screening is less fraught. When I started working on patient decision aids, we didn't have any evidence on whether there was a benefit. Now we do. We also now have strategies to limit biopsies. We have strategies to limit overtreatment. Because again, for many years, PSA is abnormal, you go straight to biopsy, you have a cancer, you go straight to aggressive treatment. And so we really needed the decision aids to let men understand that this was not necessarily the best option. I think the discussions should address the benefits and harms and uncertainties. For example, we don't know that screening high-risk men at an earlier age is beneficial, and men need to understand that. We also need to let them know what is going to happen downstream, that there will be biopsies, there could be treatment, and I think this is an opportunity to put in a plug about active surveillance, letting men know that if they get screened, they may be found to have a low-risk cancer, and they have different treatment options aside from aggressive treatment. I think we should provide patient decision aids. And I think ideally patients review these decision aids at home, be able to discuss them with friends or family so that when they come into the doctor's appointment, clinician appointment, they are much more informed and can have a much more focused and briefer discussion. I highlight the guideline, the decision aids from the American Cancer Society, the CDC, and the Mayo Clinic. These are publicly available. Decision aids that I think are better are those issued by HealthWise and the EBSCO Health Option Grid. Unfortunately, these are proprietary. Even though I worked on the UpToDate guideline, patient decision aid, I don't highly recommend it. It wasn't interactive. And for some reason, UpToDate wanted a higher reading level, somewhere around 9th grade. And you really need to be much less advanced for patients getting screened. The other thing is I think we need to use clinic-based decision support tools because we can't count on people having time to look at the decision aids at home. And so there aren't that many. This is one that comes from the Preventive Services Task Force. Is prostate cancer screening right for you? Summarizes what the guidelines are. It takes people through the pictogram of how many men, if 1,000 men offered screening, how many are abnormal, how many are found to have cancer, how many have complications, what are the benefits and harms. But this is kind of limited. What I actually like is the clinic-based decision aid that was developed by the Agency for Health Research and Quality for lung cancer screening. And again, it talks about potential benefits. It shows the pictogram, talks about harms, but it also talks about other issues you should be considering, talks about insurance coverage. And then what you see on the right side, this is the values clarification exercise, asking patients what is important to you when deciding. How important is it to find early cancer? How concerned are you about false alarms? And then depending on how they fill in the circles, when you look at it, they're going to be able to tell themselves whether they're leaning towards screening or not. And then there's a question about what is your preference. And so I think this is helpful for educating patients with concise information and again, supporting a better discussion with clinicians. But the other thing is clinicians need information. So this is a clinician summary, just 2-pager, that talks about the evidence, the studies that generated it, what the eligibility criteria are for screening, talking about the benefits and harms and other issues for eligibility and downstream complications. And I really think that having information like this is really important for clinicians as a reference to help them better lead these discussions. I don't think there's really a lot out there right now in this area. I am hoping that my role in the updating the lung cancer or the prostate cancer screening guideline for the American Cancer Society, we will develop such products. The other important area that we can intervene on to improve the quality of screenings is to limit overdiagnosis. One of the things is in our hands in primary care. Do not screen men who are too old and sick to benefit or unwilling to consider invasive diagnostic procedures or treatment. Use strategies to limit biopsies, increase detection of clinically important cancers, and minimize detection of low-risk cancers. There's an increasing role for MRI. So MRI now is used to create what are called the PI-RADS scoring system. So this is the equivalent to lung RADS for lung CTs, for BI-RADS for mammography. Studies have shown that if patients don't have very abnormal findings on MRI, they may not need to even get a biopsy. If they do have abnormal screening findings on MRI, then the biopsy can just target those areas rather than doing the systematic biopsies. So again, reducing harms, risk from complications from biopsy, but also reducing the chance of finding clinically unimportant cancers. There's also some suggestions about using biomarkers to improve specificity for identifying high-risk cancers. So my recommendations, I think you have to defer the biopsy decisions to urologists. The practical consideration is urologists may have a specific testing protocol, and you don't want to be ordering tests that they don't want. And then, again, from my experience as an expert witness, I think a legal issue. We don't know what the malpractice risk will be if biopsy decisions are based on primary care evaluations, particularly if we say, well, our tests show that you don't need a biopsy, because I am very concerned that down the road, if a cancer is diagnosed, that there's going to be legal liability for the primary care clinician. The final step is limit overtreatment. And that means supporting active surveillance. So I was part of a study called PREPARE, which was conducted in Kaiser Permanente, Northern California. And we enrolled over 1,600 men who had just been diagnosed with a low-risk cancer. And we looked at the treatment decision-making factors. What we saw is in terms of selecting active surveillance, key factors were the fact that a urologist recommended it, that men were aware of their low-risk status, they were aware of active surveillance, that they had concerns about treatment-related quality of life, that they had a lower clinical stage, but they also had greater prostate-specific anxiety. For men who selected active treatment, the key determinant was valuing cancer control. This was particularly true for men with a family of prostate cancer deaths. They wanted that cancer out. They also wanted responsibility for the decision. This was not something they wanted to discuss with clinicians. They wanted to guide the treatment. So how does that mean? Well, we can offer supportive and educational interventions to improve the quality of treatment decision-making in men with low-risk cancer, or these can be used to decrease anxiety and distress during active surveillance. It seems that most of the issue around anxiety and distress is that initial decision to select treatment. A meta-analysis of a number of studies showed that about only 20% of men switched to active treatment in the absence of clinical progression. Again, I'm a big proponent of decision support. I actually developed decision aids for prostate cancer treatment, but the evidence is not all that supportive. A couple randomized trials of decision support that were delivered through urology practice. One was a web-based treatment preference tool, did not significantly increase uptake of active surveillance among men with low-risk cancers, 66% versus 54%. But it's actually striking that the control group had 54% uptake of active surveillance, and that was because these studies were conducted at academic and VA sites, which are much more likely to support active surveillance. Another study showed that treatment decision aid did not significantly increase prostate cancer knowledge in diverse community population, which is really the target for educational interventions, but they didn't assess, or at least have not yet assessed, whether treatment is effective. So what are my recommendations based on this? I think as clinicians, primary care clinicians need to be addressing active surveillance as an option for low-risk cancer at the time of the original screening discussion. And you have to refer patients to urologists who will implement testing strategies that guide biopsy decisions to increase detection of high-risk cancer, decrease detection of low-risk cancers, and urologists who consider active surveillance to be an appropriate option for managing low-risk cancers. So my conclusions, prostate cancer is an important public health problem. Black men are disproportionately burdened. Screening has proven benefits and harms, but there are uncertainties about the benefits and harms of early screening for high-risk men. The fact that we've been seeing these conflicting guidelines over the decades reflect differences in interpreting and applying evidence. I think screening is a preference-sensitive decision, and so we should have a strategy to be routinely offering to discuss prostate cancer screening with healthy men aged 50 to 75. I think we should begin at either age 40, 45, or 45 in high-risk men. We need to present the benefits, the harms, and uncertainties, and let them know what the downstream outcomes could be. I think using decision support tools is important. Screening should only be every 1 to 2 years. Digital rectal examination is optional. Refer patients to urologists who will optimize biopsy decisions and offer active surveillance. Thank you for your attention. Glad to take questions.
Well, thank you so much, Dr. Hoffman, for such a clear and balanced presentation. Thank you to Dr. Clavin, who was indeed watching and was grateful for the talk. Happy to have you with us and for the sponsorship of this great program. A couple of questions have come in. First off, comments, many thanks for this exceptionally clear and pragmatic talk on a challenging body of evidence. Would you comment on the optimal time interval between PSA tests? I believe that one of the European studies tested every 4 years. Could you comment on frequency of PSAs in the United States?
Sure. The issue with the frequency is a trade-off between basically false positive overdiagnosis. The US study, which screened annually, was negative. The European studies, there's a lot of heterogeneity. Some screened every 4 years. Sweden screened every 2 years. Sweden actually had the most impressive results. And so I think a lot of guidelines have come down on that every other year screening. And so I think that's the best balance. The question that wasn't asked, that is still up in the air, is what threshold should we use? The US considers PSA cutoff of 4 as the threshold. Actually, the European study used a PSA of 3. And guidelines so far have kind of hedged on it. They basically, the urologists say, well, you have to consider a number of factors. I think that the American Cancer Society guidelines, we will try to previously set 4, and I think we're going to also try to come up with a number recommendation.
Great, thank you. An additional question regarding laboratory studies. So if the screening PSA is high, are there other biomarkers that are appropriate to order, particularly in the primary care setting as a patient may be awaiting their visit with urology?
A couple things. I think PSA that's elevated should be repeated. I wrote the up-to-date chapter, and to be consistent, I said if it's less than 7, it should be repeated. There's a lot of false positives. So urinary tract infections. So you need to ask. I don't routinely recommend getting a urinalysis, but ask men before you repeat it. Ejaculation can falsely increase PSA. So repeating it in about a month, and if it's still abnormal, I think it's the most prudent strategy is to refer to urologists. There are biomarkers. A lot of them are proprietary. You have to pay extra for it. May not be covered by insurance. And again, you don't know what your urologist is going to want to be ordering. So I think both for clinically and convenience for the patient as well as malpractice, I defer those decisions to the urologist.
Great. Many thanks for your outstanding work on shared decision-making and on clinical support tools. In the absence of an alternative at the moment, I myself use the one-pager USPSTF infographic, which is digestible with a patient. As this area has evolved, I think my challenge with its use is really doesn't incorporate in use of MRI that may change the landscape of biopsy, nor active surveillance. And I wonder if you have any specific language or recommendations that might add that layer to the use of this tool.
Yeah, I think basically we need decision support tools. The big question is how to use MRI, and that's going to depend on the system, healthcare system. It's also going to depend on insurance coverage. When you start saying, well, there were some studies actually, there was a modeling study that took the extreme position. What happens if we screened with MRI? And of course, that was not going to be very cost effective. But one of the concerns is that if you require MRI, it's going to increase disparities because access and coverage for MRIs is going to be much more challenging. I think that question, you really need to understand what your urologists and your healthcare system are going to do. And again, active surveillance, I think, when I would screen patients and I have this discussion, I show them the decision aid, I say, you need to recognize that screening is likely to find low risk cancers that don't need to be treated. And you need to recognize that one of the options is going to be monitoring. And again, we haven't really had great success with showing that decision aids work, but I think at least the clinicians should explain that that could happen downstream to the patients. And again, work with urologists who will support it.
Mm-hmm. Yeah, thank you so much for that. I know we have a busy agenda in the primary care setting, and yet it has been so helpful to prepare some of these conversations for what patients might expect when they cross that next step. Are you recommending that we give our patients any guidance for things to avoid or timing of doing their PSA test? Or are you saving that guidance for, say, the first PSA comes back mildly elevated and then we're getting our repeat? Should we be doing anything to avoid false positives?
Yeah, I mean, I think the things that you need to avoid for false positive from the get-go, someone who's had a prostate biopsy, someone's who had a urinary catheterization, someone's had a urinary tract infection. So you should give those time. There were some suggestions. So obviously ejaculating, making sure they not ejaculating within 48 hours of the test, making sure that they don't have any urinary tract symptoms. There was some question about whether 100-mile bike rides would cause false elevations. That's probably not been an issue, but most of the most egregious risks for false positives are pretty obvious. So again, biopsies and catheterization. And I don't really talk about if you have the discussion in clinic and someone wants to go ahead and get screened, I would just send them down to the lab that day.
Something to be said for keeping it simple.
Yep.
Great, thank you. I know your emphasis or your area of expertise is in screening. I wanted to return to some of the questions of health equity and the disparity seen on a variety of clinically important outcomes between self-identified Black men in the United States. It looked like even though there were some similarities in screening rates, that there was really a large disparity with regard to advanced prostate cancer and prostate cancer death outcomes. Do we understand where a lot of that is coming from?
I think part of that is because we're not screening early enough. I mean, there's that 5 to 10 year lag. Incidence rates are higher in Black men earlier than in white men and other racial ethnic groups. And that basically means that they have more years to be progressing. And you see that in the higher rate of distant stage cancers. And so I think, the screening rates were comparable for men over 50, but and even though they were slightly higher in Black men, for younger men, they are at so much higher risk that a rate of 20% screening is really unacceptable.
Yeah, thank you for that. And I wondered, pigtailing off of that, what is the discussion with regard to accepting the risks of, or potential harm of screening in a younger population universally in order to provide the benefit to that potentially more vulnerable population? How is the discussion around that?
Yeah, the discussion about screening younger men, first of all, the recommendation a lot is just get this baseline. And they show is that, if your PSA is above the median for men in their 40s, then you should be thinking about getting screened, again in 2 years or 5 years. And if you're not, then wait till you're 50. So they're not going to find many cancers at that early stage. So it's really going to be creating a strategy for downstream screening. However, men who are self-report as Black may be having more cancers at that earlier age. The issue is a trade-off, because it's finding those cancers at an earlier stage may prevent prostate cancer death, but it also means that you're going to be facing the treatment complications at an earlier age. And so, erectile dysfunction and urinary incontinence may be less concerning for a 65-year-old man than for a 45-year-old man. And so that's actually a discussion, and we can't tell the patient what is important to them, but they need to understand those potential options to make the best decision.
Yeah, very complex. Thank you. Have you seen any studies or in your own experience have any good examples of clinics or systems that have had success in operationalizing, providing shared decision-making tools consistently to patients, either to review at home or done in clinic? Any examples we can learn from?
Well, look north. Group Health, who no longer exists, actually adopted a suite of the decision aids that were developed by the Informed Medical Decision Foundation, and they were regularly delivering them in a variety of settings, particularly prostate cancer screening and treatment, also orthopedics. And they showed that again, showed increased knowledge and also showed that it decreased the uptake of elective procedures. A lot of these decision aids have been developed at the Massachusetts General Hospital. They also have a long track record of being able to distribute these. It's incorporated into their medical record. So there's actually a button they push, and that way patient, it used to be we would deliver DVDs, they would deliver DVDs, and now it's online. So those are the groups that have made it the most, shown the most effective way of integrating into routine practice.
Thank you. Feels like a powerful way to leverage our electronic medical record. We have had some experience with statin for primary prevention, Mayo Clinic decision aid embedded in the medical record. Perhaps more to come for prostate cancer screening. I will check once more for any further questions here online. And seeing none, I will respect us coming up to the top of the hour. And thank you so much for your expertise and clarity and your ongoing work in this important realm. We will eagerly await the updated guidelines and the updated decision support tools. Thank you, Dr. Hoffman.
Thank you. It's a pleasure speaking to you and appreciate the invitation.